Now, there is an old myth which says that heart disease is a man's disease, but the truth is that it is the leading cause of death for both men and women. A woman is just as likely as a man to get CAD, but certain aspects of the disease, like the risk factors, the symptomatology, can be different. Now, the reason to reiterate this topic here is to re-emphasize the various aspects of cardiovascular disease in women and its gender differences, so as we can take steps to prevent it, spot signs of it early, get treatment for the condition, prevent death and morbidity. Acute MI usually presents as a catastrophic event, and a prompt, appropriate treatment is critical for a favorable outcome. In females, particularly acute MI, is inadequately studied, it's poorly managed, and has a worse outcome as compared to males. So, in women, leading cause of mortality, understudied, underdiagnosed, undertreated, annual cardiovascular disease mortality remain greater. More women living and dying with cardiovascular disease than men is a reality. The gender bias, different plaque characteristics, greater role of a microvascular disease, less severe obstructive disease of epicardial coronary arteries. There's higher prevalence of diabetes in women, of heart failure, of hypertension, depression, renal dysfunction, non-STEMI and non-obstructive CAD. 6.6 million US women have acute MI, and within less than 1 year of a first acute MI, 26% of the women and 19% of men will die. Within 5 years of an acute MI, more women than men will die. That's 47% versus 36% of men, and they will have more heart failure and suffer from a stroke. If you look at the epidemiology of CAD in Indian women, this is the DMAT registry, 21% were women, 1,500 plus patients. The women were older than men, more hypertension, more diabetes, similar incidence of dyslipidemia and stroke. 6,000 plus patients, Ahmedabad study, 17% were females, higher prevalence of hypertension, diabetes, and obesity. CABG and PCI both were used less often to treat women, and medical therapy was the preferred option in them. Characteristics of CAD in women, the spontaneous coronary artery dissection is seen more, coronary artery spasm, they have longer hospitalizations and higher in-hospital mortality, and more bleeding complications are seen in women. This is typically the spasm which is seen, which is produced by the ergonovine and normalized with the NTG immediately. Spontaneous coronary artery dissection, it's a rare cause of acute MI, seen more in young women, prevalence about 0.2 to 4%, associated with peripartum, postpartum status, OCP use, exercise, and underlying connective tissue disorders and vasculitis. The symptoms, well, the symptomatology when you talk about in women is a little atypical. Why? Because the chest pain, it's not typical. It's a sharp, pleuritic, burning, aching, sometimes to the back, to the jaw. They have flu-like symptoms. They complain of upper back chest pain, unusual shortness of breath. They complain of dizziness, generalized weakness, generalized anxiety, indigestion, palpitations, difficult to localize to the chest. So why do women delay in seeking treatment? It's possibly due to a lack of awareness of the risk. There's a passivity, there's inaccurate symptom attribution. There are barriers to self-care, older age, lower education, and socioeconomic levels, and also interpreting the symptoms as non-urgent. Sometimes they think it's temporary, so they consult with a physician or a family member, and there's also a fear and embarrassment linked to coming up with the problem. Treatment of acute MI, women are less frequently referred for appropriate treatment, more mechanical complications and heart failure. Ventricular arrhythmias occur at similar rates, more favorable outcome with PCI as compared with thrombolytic therapy. STEMI revascularization, thrombolytic therapy, yes, higher morbidity mortality as compared to men, as shown in the GUSTO trial and the SN2, but multiple relative contraindications would include older age of women at presentation, smaller body size, but it is beneficial and does reduce the mortality and morbidity. With PCI, women benefit the most, as was shown in the GUSTO 2B, but angioplasty had 56 deaths in women as compared to 42 in men. Vascular complications, need for blood transfusion, occur more in women. Female sex was considered to be an independent predictor of bleeding. So DES reduced death or MI and reduced target vessel revas. CABG surgery, women were generally older and sicker, increased risk of in-hospital mortality, less likely to receive the Lima graft. There was more renal failure, neurological complication, post-operative and MI in men. Non-stemming, more complications were seen, more bleeding, heart failure, shock, renal failure, reinfarction, stroke, more readmission, but they also benefited from an invasive management. Medical therapies, well, women fared the same as men. Consideration of weight and renal dosing needed to be done. Hormone replacement therapy, antioxidants not to be used. Aspirin, clopidogrel reduced the risk of a major coronary event. Medical therapy, non-selective beta blockers to be avoided in those whom it's due to coronary artery vasospasm. ACE inhibitor improves survival in women, but their pregnancy category C for the first trimester, category D during the second and third trimester. Women do benefit from lipid-lowering therapy, but statins are pregnancy category X, avoid during pregnancy. Yes, non-pharmacological treatment, cardiac rehab, referral and participation, again a class 1 indication. Look at the trials, radial access was associated with a reduction in bleeding and vascular complications in women. In the Worker study, women failed to assess the risk of heart disease. Women had limited access to preventive cardiac care before NMI. If we look at this Indian study, sex-related difference in outcomes for patients with STEMI, a Tamil Nadu STEMI program subgroup analysis, you would see the age at presentation female patient was significantly later, and diabetes, hypertension was more. Tobacco use was less in women. Symptom to first medical contact in female patient is significantly delayed compared with the male patients. More females were likely to receive fibrinolysis only, be discharged without any further treatment. Clinical outcomes, male versus females. There was more mortality 1 year in hospital and 1 month, and this persisted into the younger population. Logistic regression analysis of variables predicting mortality at 1 year, age, female sex, and a systolic BP less than 100 at presentation were the only significant variables that contributed substantially to mortality at 1 year. So women are generally 6.6 years older than men at presentation. 11.3% of MIs in women occurred in the age group less than 45 years. Hypertension, diabetes increased the risk 4 to 5-fold in women. They presented to the hospital 45 minutes later. Women have more chance of non-obstructive CAD, and they're predominantly younger, middle-aged women with preserved LV systolic function who had this possible plaque erosion with subsequent thrombus formation. We look at this large study, 17,000 plus patients, 37% women less likely to receive guideline-directed medical therapy, less likely to undergo revascularization, and have a worse in-hospital outcome. So, the take-home message, cardiovascular disease is an equal opportunity killer. Sex differences occur in the pathophysiology, in the clinical presentation of MI, and they affect the treatment delays. Recommended perfusion therapies for acute MI in women are similar to those in men, but bleeding risk and other complications remain gender biased. So, older age, higher prevalence. Can I go back to that? Higher prevalence diabetes, hypertension, delayed presentation, atypical symptoms, less likely to receive guideline-directed medical therapy like primary PCI, more bleeding, mortality is twice as in men. In an Indian study, the Tamil Nadu study, it was 3 times then in men. Ladies and gentlemen, thank you so much.